Society. Also with us is our erudite scholar, Professor Amam Mbakwem, and we also have other members from the Omron New Heights Farmer Group. I guess they will introduce themselves as we move along. My name is Oladipo Fason. I'm the Secretary General of the Nigerian Hypertension Society. Taiwo, do you want to introduce yourself briefly?
All right, thank you, Dr. Fason. Thank you, very professors, doctors in the house. Thank you for the opportunity that you have given us, Nigerian Hypertension Society, for commemorating World Heart Day. It says don't miss a beat. We don't want to miss any beat at all. All right, so my name is Taiwo Oladiton. I'm the product manager for the Omron category with New Heights Pharmaceuticals Limited. And it's good to have everybody here. And I'm sure that it's going to be very exciting and educating. All right, have a good time. Thank you, sir.
Thank you. Thank you. Thank you so much. So at this point, I'm going to call on Professor Simeon Isezo, President, Nigerian Hypertension Society, to give the opening remarks.
Thank you very much, Secretary, Nigerian Hypertension Society. Good afternoon, everybody. On behalf of New Height Pharma, ably led here by Taiwo and the Nigerian Hypertension Society, it's my pleasure to welcome our sponsors, partners, distinguished speakers, and participants to this 2025 commemoration of World Heart Day. It's difficult to separate hypertension from the heart. The heart is one of the target organs affected by hypertension. And the topic, healthy heart across all age groups, is very quite timely. And we are lucky to have well-experienced speakers that are interested in this topic, but not only, in fact, not only from childhood to adulthood, but even from the womb, as typified by Professor Amam Mbakwem. It's important that children are coming in this program of Children's Heart. This became very obvious during the World War, when autopsy of young adolescents, American soldiers that died showed that they had features of early features of coronary artery disease. So what we see in adulthood starts from childhood. We are now beginning to have quite high burden of childhood hypertension, childhood obesity, and I think the earlier we start tackling it from childhood, the better. So I want to wish all of us a very fruitful deliberation. Once again, I welcome you all. Thank you very much.
Thank you, sir. Thank you, Professor Isezo, for giving us the opening remarks. I'll call on Taiwo to briefly talk about the house rules so that we can go full steam ahead. You need to unmute.
Thank you, sir. Yeah, I'm here. I just want to confirm that can all see my slide. All right,
yes,
so we have a few ground rules for our webinar today. Remember that it's World Heart Day, and I want to say Happy World Heart Day to everyone. While we're at it, we want to encourage that we stay active throughout the sessions, okay? Also wanted to note that we are streaming live on all platforms. Okay, on Facebook, on YouTube, on Instagram, we are all live, so you can share the program with friends and families to join in and take a few lessons out of today's program. It will be worthy to know that we'll be taking questions on the chat group. So if you have any question at all, at any point in time, please indicate that question on the chat group. We will be here to take them at the end of all presentation. We also encourage that you like us on all social media platforms. We are on Instagram at New White Farmer, on Facebook at New White Farmer and Nutraceutica. We are also on Instagram and Facebook as Omron Healthcare Nigeria. So we implore that you come to our page and enjoy your time. There's also a goodie that we're going home with at the end of this webinar, so watch out for it. Thank you, sir. Over to you, Dr. Faso.
Thank you. Thank you so much. So I'll go right away to introduce the members of the faculty. Permit me to start with Professor Amam Mbakwem. Professor Amam Chinyere Mbakwem is a professor of medicine at University of Lagos and a consultant cardiologist at Luth. She sits as the current head, Department of Medicine of both College of Medicine, University of Lagos and Lagos University Teaching Hospital, Luth. She completed her residency in internal medicine and cardiology at the Lagos University Teaching Hospital and had a fellowship of West African College of Physicians in 1997. She had further training at Wolfson Heart Institute in Tel Aviv, Israel, and Azienda Sanitaria, Tuscany in Italy. She was awarded a fellowship in medical education in 2007 by the Foundation for Advancement in International Medical Education and Research, FIMA Institute, in Philadelphia, USA. She's published over 110 peer-reviewed journals. She's published over 110 publications in peer-reviewed journals and has contributed to book chapters and presented over 100 abstracts at scientific meetings. Her area of interest includes heart failure, systemic and pulmonary hypertension, heart disease in women, and effective communication in disease management and
Sorry, is it just me? I can't hear Dr. Faso anymore.
Dr. Faso, we cannot hear you again.
Okay, someone mistakenly muted me, I guess. I've unmuted myself now.
Yeah,
so she's immediate past director of the Medical Education and Development Unit at the CMUL, that's College of Medicine, University of Lagos, and has supervised over 21 fellowship dissertations for the award of both Fellowship of the West African and National Postgraduate Colleges. She is the Vice President of World Heart Federation and, of course, the past President of the Nigerian Cardiac Society and Vice President, West African Region of PASCA. Please help me in welcoming Professor Amam Mbakwem. You can go ahead now.
Okay. Thank you so much, Dr. Faso, for that kind introduction. I would like to appreciate the Nigerian Hypertension Society and New Height Farmer for inviting me to take part in this program. I'm glad to be here, and I hope you are too. I'm trying to get this out of my way. I'm seeing, okay. I'm trying to get the people out of my way. I'm sure you can see my slide, right?
Yes, ma, we can.
Okay.
Yes,
Yes.
ma'am, we can see it, ma'am.
Okay. So like Taiwo had said, Happy World Heart Day. And like the theme for this year's celebration says, don't never miss a beat. So I've been asked to talk to you about healthy hearts, healthy futures, safeguarding cardiovascular health in midlife. I've been introduced. I have nothing to declare except that New Height Pharma and Nigerian Hypertension Society have asked me to speak at this meeting. So what I'll do in the few minutes that I have with you is look at the burden of cardiovascular risk factors in middle age. So specifically looking at hypertension, dyslipidemia, diabetes, obesity, and stress. And then early detection and management of silent cardiovascular diseases. The role of lifestyle modification, looking at diet, physical activity, smoking cessation, and stress reduction. And then importance of regular screening and risk assessment in midlife to prevent premature cardiovascular disease. And then we'll conclude. So as an introduction, we know that CVD accounts for about 20.5 million deaths globally. And this represents about 33% of all deaths when you put all the deaths that are happening around globally. So CVD is an important contributor. But what has happened is that the trend in the burden, it's different depending on where you live and where you're coming from. In the global north, it's going down. But what we've seen is that it's rising in the low and middle income countries like Nigeria, where you and I live. And a third of the mortality would occur prematurely. So these are people less than 70 in the 60s. So it's an important issue that we need to deal with. So I took this cartoon from the Global Burden of Disease, looking at age standardized and disability adjusted life years. So if you look at on the x-axis, if you look at it shows the country. So if you start from the right-hand side of the slide, you'll find countries like high-income Asia, you find Western Europe. 1 minute, let me see if I can get my slide, if I can get my pointer on. Okay, so you see high-income Asia, you see Western Europe, you see the Americas. But if you go towards the left of that slide, you see the Eastern Europe, that is behaving like almost like low middle-income countries. You see Central Asia, you see Central Sub-Saharan Africa, you see Africa North, East, West, and we see that our burden, the dialysis is actually much higher, for these poorer countries who have very fractured health systems, as opposed to the higher income countries that have the wherewithal, to look after patients with this cardiovascular disease. Okay, looking at this just shows the burden attributable to selected risk factors globally. And when the president was giving his opening remarks, he was talking about hypertension, being an important or very important risk factor for cardiovascular disease. So if you look at the metabolic risk factors, so if you're looking at high blood pressure, the bar is tallest. If you're looking at then HDL, then body mass index, then fasting sugar, then kidney dysfunction. But we know that there are other things that are contributing to cardiovascular disease presently that has been shown, from different studies. Environmental risk factors, things like ambient air pollution, looking at the ambient particulate matter, PM 2.5, that the larger particulate matters will cause respiratory diseases because they get stuck in the respiratory system. But the smaller one, the 2.5, will get into the bloodstream and, induce inflammation in the vasculature. So pollution from solid fuels, and we know that in these low and middle income countries, this is where we're still using biomass, and a lot of cooking happens indoors. So the pollution is both outside and inside. Then temperature changes as well. And then we'll looking at behavioral risk, dietary risk. We're all adopting the Western diets and taking all the refined carbohydrates and high sugary drinks, and then smoking, secondhand smoke, high alcohol use, low physical activity. So this growing trend we demonstrated in a study we did a few years ago. We looked at trends and outcomes of cardiovascular disease admissions and the Lagos University Teaching Hospital. We did a 16-year review. And we found that there was, marked continuous increase in admission trends for CV events and mortality. So the first, this orange bar tells you what has happened, with stroke admission for stroke patients with stroke. And so this analysis looked at divided the 16-year period into quadrennial, sections, and we see that from 2002 to 2005. As you go on, into those quadrennial sections, there is a straight line increase in, stroke admissions. This is also followed by, stroke mortality. Heart failure, also the gray bars shows a straight line increase over the years. Mortality, maybe not as much. Then you have hypertensive heart disease, you have acute coronary syndromes, and you have ACS deaths. Okay, and this has been increasing over time, and this has happened in tandem with the increase we saw with admission burden for patients with cardiovascular disease. And what has been driving this burden? We know that this is majorly driven by poorly controlled risk factors, whether you're looking at hypertension, diabetes, dyslipidemia, obesity, sedentary lifestyle, aging. And for the population, we're getting older. So, there's a chance to develop any of these risk factors. And then, of course, the environmental factors have taken up an appreciable role recently. We know that air pollution, which I talked about, global warming. And then for those of us who live in big cities like Lagos, with all the pollution, the exhaust from burning of fossil fuels, the places, dusty industries are not regulated. So we are sitting like on a keg of gunpowder if we don't really do much to get this out of the way. So what are the common factors driving the increasing burden of risk factors? So I'm looking at, sorry, I didn't say that properly. So we find that these increasing burden of risk factors have commonalities, so the cardiovascular, the risk factors driving, the issues driving hypertension, are also driving, diabetes, also driving dyslipidemia. So it's like a conundrum. Everything is just acting in consonant and helping each other. So when we look at hypertension, globally, about 33% of the world population, that's about 1.4 billion people, aged between 30 to 79 years, are said to be hypertensive. But that's not even the issue. But look at 44%, almost more than a third are unaware that they have hypertension. Just over a third are on treatment, but look at the control rate, just about 23%. But this is global, mind you. And when we come home, we look at what we're doing, whether we're doing well or we're not doing so well compared to the global data. And when we look at diabetes, 11.1% for those 20 to 79 years, 40% of them remain undiagnosed. And the increase in this burden is driven by things like obesity, diet, physical inactivity, and aging. And you find that these are also factors that are driving the increasing burden of hypertension and the cardiovascular disease that we're talking about this evening. I just put this cartoon to just give you a pictorial, view of what is going on. So look at the burden. So we have 600 million people undiagnosed, only 800 million people diagnosed. So let's leave the undiagnosed people and just focus on those who we've diagnosed. Out of that, only 630 million of the 830 are treated. And only 320 million of that 630 are controlled. So what are we doing with this 310 million that are not properly treated, not controlled, or the 160 million that are diagnosed and not yet on treatment? And then when we add that to the burden, to the 600 million that we haven't even diagnosed, that gives you an idea of the problem that we're dealing with. What of obesity? In 2022, it said that about 1 in 8 people are living with obesity worldwide. And what's been shown is that adult obesity has more than doubled since 1990. And the annoying thing is that there's a lot of young people who are obese. The adolescent obesity has quadrupled. Somebody said that this, which is not a good statement, is not a good place to be at, that we are getting into the era where parents will survive their children, because the children are carrying a heavy burden of the cardiovascular risk factors. In 2022, 43% of adults aged 18 years above were overweight, and 16% of that number were living with obesity. Look at the figure for children. 35 million children under the age of 5 were overweight. And then when we look at adolescents, looking at people 5 to 19 years, over 390 million people are living with obesity. And because, the dietary thing had changed, a lot of consumption of ultra-processed foods, taking of sugary drinks, and sedentary lifestyle. Dyslipidemia, we're not doing any better. The global prevalence was put at 28.8% for hypertriglyceridemia, 24% for hypercholesterolemia, low HDL 38.4, 18.9 for high LDLC. Of course, men, well, I was surprised that men have higher prevalence of hypertriglyceridemia, but it's a man's world anyway. So, the men always take the driver's seat, so they can also have their hypertriglyceridemia, where we come behind them as a women. But the women had high frequency of low HDLC. The highest prevalence of low HDLC and mixed dyslipidemia patterns were observed in the Middle East and Latin America. And the temporal trends have shown there's a progressive increase in hypertriglyceridemia and low HDLC, but there's a bit of a decrease in hypercholesterolemia and high LDLC. So let's come back home and look at what is happening in Nigeria. Looking at hypertension, we're looking at diabetes, obesity, dyslipidemia, smoking, air pollution. Are we doing any better? So the trends in Nigeria is also showing this rising burden of hypertension. A meta-analysis, that was done by Adeloye in 2010, gave the prevalence of hypertension at 28%. He repeated that analysis in 2020, and the figure had gone up to 32.5%. Just compare that to the nationwide survey that was published in 1997, where the prevalence of hypertension was 11%, but bear in mind that the cutoff for hypertension at that time was much higher than what we're using now. And then Odile and his group, showed that the prevalence of hypertension worldwide, using the same kind of instruments and the same survey, was now 38.1%. And the thing that really bothers me about that data is that the dichotomy, because in the earlier surveys, if you're living in the urban cities, you are more likely to have hypertension compared to people living in the rural areas. But that dichotomy has been wiped out, as shown by the study by Odile and his group. What of obesity, diabetes and obesity? There's also been a rising, trend. A meta-analysis done in 2018 put the prevalence of diabetes in Nigeria as 5.7%. Compare that to the 2.2% from the national survey that was done in 1991. Are we doing any better when we look at obesity? The pooled analysis of overweight in Nigeria has been put, the meta-analysis was put at 26%. Obesity, about 15% of that cohort. And the increasing trend in the prevalence of obesity in Nigeria from the study was majorly seen in people who were living in the urban settings. What of hypercholesterolemia? So I also looked at this pooled prevalence from a meta-analysis. 38% of people living in Nigeria, have hypercholesterolemia. Women slightly higher compared to the men. And then it's highest in the South and lowest in the Southwest. The explanation is very difficult to understand, and the Northeast, but urban dwellers show the higher rates compared to the rural dwellers. And it's estimated that over 8.2 million persons aged more than 20 years had hypercholesterolemia in 1995. But by 2015, this figure had gone up to 21.9 million persons, almost 22 million persons. So we're not doing any any better at all. We are doing as bad as the global trends that are happening. So I've been asked to talk about, what's happening in midlife, trying to prevent, cardiovascular diseases in midlife. But I'm saying that if we're doing that in midlife, it's actually too late. It's like shutting the barn after the horse had bolted. And why am I saying this? Because the period of yes, midlife will represent the period of manifestation, the burden, the greatest manifestation of the disease process. But the disease process starts very early, even in childhood, up to teenage years. And for atherosclerosis too, for us to really prevent all this, from happening, we need to, take a step backwards and go back to early life. And we're talking about primordial and primary prevention. So what's been shown is that stages of atherosclerosis development, which is a major, cause of atherosclerotic cardiovascular disease, that in childhood, we begin to see the earliest signs, which are fatty tricks. These are common in children. The president mentioned a bit of it when he was talking about the autopsies that were done during the World Wars. So as children, by that time, with all the risk factors, they're already laying down the fatty streaks. By the time they're into their teens and their 20s, plaques have started forming in the arteries. By the time they are 30, their 30s and their 40s, then the plaque accumulation and arterial changes become more widespread. And by midlife and older age, the disease can become more severe and symptoms may start to manifest. So you can agree with me that midlife is a bit too late for us to start modifying and preventing cardiovascular diseases from happening. So I just put this cartoon to show you what has happened. Risk factors associated with developing atherosclerotic plaques in young population, not very different from what is happening in adults. Our children are getting obese. The low density lipoprotein cholesterol is also rising. They are developing atherosclerotic plaques very early, and they are eating all sorts of things, ultra processed food, the burgers, the burgers, the fried, and with the chips, all sorts of the donuts. They are smoking, and not just smoking, they are smoking all sorts of things. We are worried about cigarettes, but people are smoking all sorts of things. And then a lot of young people now are moving into vaping. But studies have shown that vaping is not as innocuous as we thought it was. And also childhood hypertension, which the president had mentioned in his opening remark. So what role has lifestyle got to do in modification of all this process? And I'm saying is of paramount importance. Why? Because the risk factors coexist and effects are multiplied and not just additive. So by the time we have 2 risk factors or 3 risk factors, they don't just add up, they multiply into each other. And because of the commonalities, it means that the gains will be much more. Because if I'm controlling the risk for one aspect of the disease, I'm going to get benefits for other aspects as well. The initial and crucial step in prevention and management of risk factors and CVDs, lifestyle modification, we cannot run away from it. We can't just continue to give medications. Lifestyle modification and then medications will come in to help when we've reached the peak of what we can gain from lifestyle modification. And the steps for, so as we control these risk factors, we should move away from, disease management, CVD management, to CVD health, which is a concept I want us to take away from this meeting. Let's kind of switch our brains from thinking about disease to thinking about CV health. Sorry, that shouldn't be CVD health, CV health. And these factors may not cause just CVD, but CKM. I'm sure we've all heard about the cardio-kidney metabolic syndrome. And this will broaden the scope of prevention if we can get the lifestyle modification right. So I just put this, the conceptual diagram for CKM, just to show you where we start. This excess dysfunctional adipose tissue, starting from what we're eating, the way we're eating it, what we're doing, the sedentary lifestyle and all that. And once that accumulates, it starts inflammation, the oxidative process, the insulin resistance, the vascular dysfunction. So diabetes is hanging around the corner. Of course, hypertension, dyslipidemia, metabolic syndrome. And of course, it also leads to, ectopic fat deposition, not just in the liver, even in the heart, causing, muscle, metabolic dysfunction associated a liver dysfunction. And that also contributes to the inflammation. And of course, this fits into the glomerular function, causing glomerulosclerosis, tubular interstitial fibrosis, and chronic kidney disease. And all of them, whether you're coming from inflammation, hypertension, the CKD, will worsen atherosclerosis, myocardial remodeling, fibrosis, and cardiac prevention. So please, when we talk prevention, let's think holistically and not just think about just one disease process. So I was talking about the paradigm shift, that we should move away from CVD to CV health. And the American Heart Association now looks at 3 major criteria. So for you to have, for me to say that your CV health is favorable, there must be 4 favorable health behaviors. So you are not smoking within the last year, you have a wonderful lean body mass, you are physically active, and your consumption of that, your consumption and what you're eating, promotes cardiovascular health. And of course, also, the favorable health factors, you are not smoking, your cholesterol untreated is less than 200, your blood pressure untreated is less than 120/80, and there's also absence of diabetes, and there's also absence of clinical CVDs, including coronary heart disease, stroke, and heart failure. So management of early stages of CKM, as you can see, I'm shifting a bit from just CVD to CKM, because if we get everything corrected, we're going to get a lot more benefits. So by the time when the patient is in CKM stage 0, okay, this is where primordial prevention comes in. So this is patients who have normal anthropometric values, normal glycemia, normal tension, normal lipids. So we want to keep them here and not allow them to move into CKM stage 1, 2, 3, and get into 4. But even if they get there, proper lifestyle modification can actually move back the hand of the clock. So the AHA Life Essential 8, gives us a good construct that provides the holistic framework for achieving and maintaining surveillance of cardiovascular health. The Life Extension 8 sets out, health metrics that is used to assess and improve cardiovascular health, focusing on both health behaviors and health. And this is shown here. So the Life Extension 8 has 4 health behaviors and 4 health, CV health issues. So we're talking about non-smoking. We're talking about sleep. Sleep has become an important aspect of cardiovascular health. But when I talk about sleep, I usually, it's with tongue in cheek for those of us who live in Lagos and you live so many miles away from where you work, and you have to wake up at 4 a.m. and you don't get home till 11. How much sleep can you get, and what quality of sleep will you get? Well, you need about 7 to 8 hours of quality sleep, to maintain your cardiovascular health. What of diet? Fruits and vegetables, fish more instead of animal protein, and then regular exercise. And then when we talk about the CV health issues, your blood sugar is well controlled. We are monitoring that. Your weight is normal. You have your lean body mass, lipids are in control, and your blood pressure is normal. So the aim, using the Life Essential 8, talking about lifestyle modification, which is where I've been asked to focus, the aim is not just to prevent CVD, but to promote CV health, which the AHA has defined, and not just to reflect absence of CVD, but to include factors that would promote primordial prevention. So among the CV health metrics, prevention of obesity is the principal issue, because we know that the obesity syndrome, the focus, the CKM syndrome starts with this abnormal dysfunctional fat deposition. And then this lifestyle modification we're talking about, we need to deploy them in school, talking about school-based lifestyle programs. So we need to start it early, because the Bible says, well, teach a child, a way to, if you train up a child, the proper way, when he grows up, he will not depart from it. A child has been sedentary in front of the TV, eating all the fried things, and we expect him to make healthy choices as an adult. That won't work. Routine weight monitoring and counseling on healthy diet and exercise, we focus on the family in primary care settings. So regular screening is key to early identification and management. So we're monitoring the blood pressure, metabolic screening, and weight monitoring. Yeah, sometimes the guideline says if your blood pressure is normal, then don't measure in the next 1 year. Or I don't say that to my patients. What I say to people, what I say to the to people I come across, at any time you have the opportunity, to meet a healthcare personnel and there's a speak around, please just stick out your arm. It doesn't cost you anything, and let them measure your blood pressure. But we have to go back even further from good antenatal care, because all this what we're talking about may not really work if the child grows up, if the child in the womb faces a hostile intrauterine environment with intrauterine growth retardation. That's where they lay down, the narrow arteries, the endothelial dysfunction that will manifest as all the CVDs, we're talking about in adult life. But there's some extension to the life extension aid, okay, because other factors that come into consideration for improvement of CV health are the social determinants of health and the psychological factors. We know that recent evidence supports the brain-mind-heart, body connection with negative or positive impact, depending on whether you are anxious, anger and hostility, chronic stress, social stressors, pessimism, depression. All this will worsen the cardiovascular health. We want people to have psychological well-being, mindfulness, gratitude, optimism. And then we're looking at the social determinant of health. I mean, studies have shown that where you are born, where you went to school, how much money is in your pocket, where you live, all of them would affect your health, your cardiovascular health. So the social determinant of health, needs to come into the life extension aid if we're trying to, prevent cardiovascular diseases from happening. So as I conclude, there's a rising trend in the burden of CVD mortality, especially in low and middle income countries. Most of these occur prematurely before the age of 70. And the highest burden is in midlife. And this is driven by increasing burden of uncontrolled risk factors for cardiovascular diseases. Prevention must span the whole spectrum: primordial, primary, secondary, tertiary, even quaternary. Lifestyle modification is a key step in the prevention of CVD. The life extension aid of the AHA gives us a good framework to follow. We should shift focus to CV health and not just CVD. Thank you for your attention. Remember, every bit counts, and I'm ready to take your questions. Thank you. So far, I'm done.
Thank you so much, Ma. Thank you.
Thank you so much, man. That was fantastic, as usual. We don't expect anything less. Thank you, man. That was very educating, very enlightening. I'm sure many of the listeners will be ramping up questions for you by the time we are done. But so thank you so much. That was a brilliant presentation. Thank you so much. So we move on to primarily we were supposed to start with the pediatrician. We have an erudite pediatrician in the house. So we were supposed to take it from cradle to older age. But for logistic reasons, he couldn't join on time, but he's with us now. So I introduce Dr. Richard Nalu, a pediatric cardiologist at the University of Abuja Teaching Hospital. He has over 20 years experience as a pediatrician, and has been involved in the diagnosis and treatment of children with various health conditions, including cardiovascular diseases. He got his MBBS way back and has trained at least 19 postgraduate student candidates for Part 1 and 6 Part 2 fellowship doctors. That's fellows, consultants now. He's been an examiner at the National Postgraduate Medical College since 2015, and he had his PhD dissertation in cardiovascular changes in sickle cell crisis, an impact of arginine therapy on the pain and cardiac changes in crisis. He currently serves as the head of Department of Pediatrics at the University of Abuja and is an associate professor. Please, let's welcome Dr. Richard Onalo. You can unmute.
Thank you so much for having me on board. I'm trying to share my slides.
We can see your slide. Just click on the slideshow. Yes.
You can see my slide?
Yes, please.
I'm not seeing it here. Okay, so thank you again, once again, for giving me this opportunity. I'm sorry for coming late because of technical issues. Yes, this year World Heart Day is focusing on a healthy heart. And it's our desire to see that our children have a healthy heart. Our major constraint to that is the presence of congenital structural heart diseases that some of our patients present with, and this has been a challenge to us. This is what is making our goal of ensuring a healthy heart in our children a difficult one. So it's important for us to have a brief overview on congenital structural heart disease, how to diagnose and treat this condition, so that children that are born with this condition will have less morbidity and mortality because of their heart condition. It's important to remember that the heart originates from the lateral plate mesoderm, where the primitive heart tube is formed. And within the first 8 weeks of gestation, the heart formation.
Sorry, Prof. Can you put your slide in presentation mode?
Okay. Okay. Thank you. Are we there? Hello?
Not yet.
We are with you, but you are not in presentation mode yet.
Oh my God. Has he come? What? Please confirm.
Not yet.
Maybe you should just go on. We're not saying it.
Just go ahead, sir.
Okay. So all this about congenital heart disease takes place within the first 8 weeks of gestation, and therefore events that occur at that time account for majority of the heart disease the patient come down with. This is just an overview of the embryology of the heart and what happened within the first 8 weeks of gestation. Epidemiologically, congenital heart disease is very common. About 1% of all births are shared with congenital heart disease. Much more common in the East Asia. Virtually all forms of heart disease have been reported in Africa, even in Nigeria. In my own place here, we've seen various forms of heart disease. Among these, VSD accounted for about a third of the heart disease that we've seen. In terms of classification, just to remind us that congenital heart disease are classified into cyanotic and the acyanotic. The acyanotic tends to be more common, and this is classified into the shunt defect, which include the VSD, the PD, the ASD, and the AVSD that we are familiar with. Besides this, we have the obstructive lesions such as the pulmonary stenosis, aortic stenosis, and coarctation of the aorta. The cyanotic group are classified into those associated with low pulmonary blood flow, for example, the tetralogy of Fallon, the transposition screening, and the common missing conditions. In terms of etiology, the cause of congenital heart disease remains unknown. However, there are many associated risk factors that have been demonstrated, and predominant among them are chromosomal abnormalities such as the trisomy 21, commonly associated with atrioventricular septal defect. Other trisomies like Edwards, which trisomy 18, Patard syndrome, like trisomy 13, are also associated with congenital heart disease. Intrauterine infection, maternal illness during pregnancy, such as diabetes, maternal drug use, and exposure during X-ray exposure during pregnancy are also among the risk factors that have been demonstrated. Genetic factor also seems to play a role, as we all know that the risk of congenital heart disease increased from 1% in the general population to 3 to 6%, or 1 to 10% in the siblings or offspring, respectively. And also, some ASD are inherited in autosomal dominant or recessive pattern. Children born in high altitude and those associated with birth asphyxia and prematurity may also come down with congenital heart disease. So let's look at this.
Dr. Nalu, your slides are not moving.
They're not moving.
Yes.
Oh my God. Please confirm if it's moving now.
No.
It's not moving.
Yes. Can you sign out? Can you stop sharing and then start sharing again? Are you finding it difficult?
Is he sharing now?
Yes, but we are still where we. Okay, click on the next slide. No, I think you need to. Just.
Is he moving?
Go ahead. Yes, it's sharing now. It's moving now.
It's moving now. So sorry for that. So we're talking about the acyanotic.
Can you expand your screen? Top right hand corner.
Is he expanded?
No, not that. The one next to it.
This one.
Yes.
No.
Okay. Click it again. Okay, so that's the best you can do. Let's go on, please. You can resume, sir.
Okay. Is he moving now?
Yes, but click on resume.
Resume. Okay. Is it better now?
There's one. Sorry, Prof. Can you look at the bottom right corner? There's one scale there. There's a line at your bottom right corner of your screen where you have those icons. So if you slide it towards the right, maybe to make it bigger. If you click on the plus sign.
The plus sign.
Yes.
Plus.
At the bottom of your screen towards the right.
Oh, okay. There's no plus sign at the bottom of my screen here.
But we can see it's the one you're projecting towards.
There's no plus sign. You see video, chat, share, Q&A, show option, action.
But can you see the 58%?
Huh?
Can you see the 58% at the bottom of your screen?
58.
Yes.
Bottom right. Bottom right. Look at the
right.
bottom right of your screen. You see a plus and a negative line. Just move it to the right. Click on the plus a little.
It's not showing in my.
Okay. Maybe
Okay,
we'll just...
let's go on, sir. Let's go on. Let's go on. Go ahead, sir.
Okay, sir. Is the slideshow still on?
Click on resume, please.
Resume. Are we still there?
Yeah.
Yes, we are here with you.
Okay, so just to again take us back, looking at the acyanotic congenital heart diseases. And in terms of pathophysiology, we remember that the pressure on the left side is higher than that on the right side. So once there is a shunt lesion, there will be a shunting of blood either through a PDA at the arterial level or through an atrial septal defect or through a ventricular septal defect. And the effect of the shunt is determined by the size of the defect. The larger the defect, the more the shunt. The smaller the defect, the smaller the shunt. The other part that determines the effect is the pulmonary vascular resistance. Here is we are seeing here the moderate to large VSD. There is the increased pulmonary blood flow, and this leads to an increased return to the left atrium through the pulmonary veins, and consequently an increased return to the left ventricle. And this will give rise to a left atrial and left ventricular overload. That's the reason why they will come down with left ventricular failure. Similarly, in PDA, for those that have large, moderate to large shunt, the effect is similar to what we see in VSD. However, in the atrial septal defect, the effect is on the right side because the shunt is from the left atrium to the right atrium, and that will give rise to right atrial and right ventricular volume overload. So, unlike the VSD and PD, the ASD present right ventricular problems. So, in terms of the clinical features of this shunt defect, the features is dependent on the size of the defect. Those that have small shunt, they don't present with anything. You just found an asymptomatic patient that found a murmur. But with those with moderate to large shunt, because of the increased pulmonary blood flow, they present with pulmonary congestion, with pulmonary edema. And this will present clinically as recurrent cough, recurrent chest infection, or recurrent breathlessness. And this may give rise to feeding difficulties, which may present as failure to thrive in the patient. The shunt also, due to a ST phenomenon, may give rise to systemic starvation, which will also lead to failure to try. When you examine this patient, they are small for age, they are dyspneic, they have precordial bulge, have hyperactive precordium. The pulses are usually normal, except in the area of PTA where they have a bounding pulse. The apex may be displaced, especially when there is a left ventricular hypertrophy. There may also be a right ventricular heave in the case of those that have pulmonary hypertension. A tree may be present depending on how severe the turbulence is. May be present in the left lower spinal border or the left upper spinal border if the patient present have PTA or BSD. Blood pressure is usually normal in patients that have a shunt defect. However, in PTA, there may be a wide pulse pressure. The heart sounds are good, but it may pick a fixed splitting of the second heart sound in patients with ASD, or there may also be a loud P2 in patients that have pulmonary hypertension. Murmur is present at the left lower spinal border in patients with BSD, and is present at the left upper spinal border in patients with PTA. And the ejection systolic murmur will peak at the left upper spinal edge in patients with atrial septal defect. In addition to this, there may be signs of congestive.
Prof, your slides are not moving again.
They're not moving again?
Yes. We are stuck at slide 10.
Is it moving now?
Not at all.
Oh God. Why all this? Please confirm if the slide is moving. Any change, any difference?
No.
It's not moving.
It's not moving, sir.
Oh my God.
Okay, can we do this? Can you send your presentation to us? Maybe we'll share it for you while we bring on Dr. Siubu. What do you think,
Okay,
sir?
I'll do that now.
So send the presentation to me. I'll send you my email address now. And
Can I
then
send
we'll
you your
share it.
WhatsApp?
Yeah, you can send it to my WhatsApp, sir.
Okay.
Okay, so we bring on Dr. Siubu. Dr. Siubu. Can you sign up? Can you unshare, sir?
Okay, sir.
Okay. Okay, great. So I introduced Dr. Ogugwa Osiogbu, a pioneer geriatrician in Nigeria. She's contributed to the well-being of older adults since coming back to Nigeria from the United States, where she trained. She's provided service as a clinician, training of the healthcare workforce in West African sub-region, and also as an educator and as an advocate. She's also contributed in capacity building on aging issues as a member of the steering group of SGA Africa, an executive member of the Geriatrics Association of Nigeria, GAN. She co-facilitated the first SGA Africa Conference on Aging in Abuja in 2018, and the African Regional Conference on the Human Rights of Older Persons in Africa, Abuja 2019. She has made great contributions as a member of the Technical Working Group on Aging in Nigeria, and she has been involved in policy document reviews, hearings on bills regarding older persons, and stakeholder engagements with relevant government ministries and agencies to promote age friendliness in Nigeria. Dr. Siobu was on the panel to discuss aging and women at the maiden event, which held during the Commonwealth Women's Forum in Kigali in June 2022. She has published several journal articles and chapters in books. She has also engaged in research on non-communicable diseases. She consistently engages in activities offered for older persons in Nigeria, including media appearances. She's currently the head of geriatric unit at National Hospital, Abuja, and subspecialty head for geriatrics training with the West African College of Physicians. So, ladies and gentlemen, I introduce and welcome Dr. Usiogu.
Thank you very much, Dr. Faso, for that introduction. Good evening, everyone. Can we all hear me?
Yes, please.
And I thank the Nigerian Hypertension Society for this opportunity. So we'll be looking at that outline. Really, just to remind us that aging is a process of becoming older and is a complex and dynamic process. It results from accumulation of damage to molecules and tissues. And, you know, we've had some of the lifestyle effects on heart health from Professor Mbakwe. We've also heard that some of the changes we're seeing in the heart actually start from a very early age in life. So it is a life course process. We used to think that aging began from birth, but we now have evidence that those accumulative changes at the molecular level actually start from conception. And, you know, it's important that we talk about heart health in older people because we're having a global increase in the aging population. So as healthcare workers and our health systems must be upgraded to ensure that we're actually addressing the issues of older people. So the number for those aged 60 and above, and that's the cutoff age that we actually use. We say you're an older adult or an older person, not elderly and not aged. So we really don't like to use those terms. You are just older than the person, you know, who's 59 or 57 or 40. So that number stood at 606 million in 2000. But by 2050, it's estimated that there will be about 2 billion people on the face of the earth who are 60 and above. And at that time, for the first time, we would have many more older people than we would have children under 14. So we really have to think about how we will keep this increasing number of older people healthy so that we're not dealing with an aging population with disability. In the same vein, in Nigeria, we estimated that by 2020, we would have 10 million Nigerians above the age of 60. But the Nigerian Bureau of Statistics gave us a figure of already close to 16 million. So we're also increasing, we're also having an aging population, an exponential increase in age. So normal aging, you know, is associated with diverse changes throughout the body, but I guess because we're focusing on cardiovascular health, and these changes are accentuated by common comorbid conditions that we find with aging. And the common ones that we actually tend to find are hypertension and diabetes. We find that when we looked at our cohort of patients at the National Hospital, hypertension led the pack, and then diabetes, the third common thing that we find in our older population, degenerative joint diseases. And we found a multimorbidity prevalence of 70%, meaning more than 2 out of 3 older persons would actually have coexisting 2 or more chronic medical conditions like hypertension, diabetes, and degenerative joint disease. These aging changes are also affected by lifestyle practices across the life course. Remember, I said aging begins from conception. So everything that is happening to that fetus and the fetus is born, is the fetus exposed to good quality healthcare, is the fetus in an area like Gaza or Russia right now where there's crisis or war? Is the fetus living, is that child living in a home where there's a lot of domestic violence? all of that. Does this child start smoking from the age of 5 because, which could be indirect smoking because he's living with parents who are smoking? All that affects how our tissues and cells actually age. And the physiological changes that we find also interact with how older people actually present for disease conditions and also how they respond to therapy. So it's important that we put all this into context as we're either as a cardiologist or a nephrologist as you're managing your older adult patients. These are some of the principal effects on aging. There's increased arterial stiffness. I think Professor Bakwem had mentioned some of these. There's reduced myocardial relaxation and compliance, which tends to give them a diastolic dysfunction. With aging, there's reduced responsiveness to beta adrenergic stimulation. The sinus node function is also, and conduction velocity is also reduced. So we tend to find arrhythmias in this with increasing age. So you're going to find more of your bradyarrhythmias with increasing age than you'll find in younger people. There's increased afterload and systolic blood pressure, which again contributes to the higher prevalence of hypertension in this older adult age group. There's also endothelium responsiveness for vasodilation is reduced. So, and this has also been linked to our gut health. So there's a term described as gut dysbiosis that has to do with the imbalance in the bacteria of our gut. We know that there is normal gut flora. And when we have that disequilibrium in our gut flora, it's actually been linked to increased inflammatory state, and that has been linked to endothelial dysfunction and leading to some of the changes that we see in the cardiovascular system. There's reduced exercise response with older, in the older age population. They do not attain maximal heart rate. They do not attain, or the maximal heart rate, yes, often not attained. Cardiac output also doesn't increase as we expect, or as we see in the younger age group. The maximum oxygen extraction is also reduced significantly. So when you look at arterial versus venous oxygen difference, you don't see a marked difference like you will see in younger people. That again has been linked also to muscle mass. We know that sarcopenia starts in our 30s, and sarcopenia refers to a progressive loss of muscle bulk. So with sarcopenia, there's reduced extraction of oxygen from the muscles because of the, into the muscles because of sarcopenia. So where you have worsening sarcopenia, and there are lifestyle practices that have been linked to sarcopenia, again, very similar to what we find as what increase our risk for things like hypertension, diabetes, and consequently stroke. So smoking, sedentary lifestyle. So these are, again, issues that we have. So if you find your patient, and we do have a lot of tools that we use in assessing patients for sarcopenia, it means that that patient with sarcopenia who has existing hypertension and diabetes, you even have to be a little more intense with because of that increased risk of reduced oxygen extraction for use. There's increased risk of coronary artery disease. We have a term described as inflammaging, and that just describes the phenomenon of an increasing inflammation, chronic inflammation with aging. And the evidence for that came from the fact that when we look at older people compared to younger people, the levels of markers of inflammation, interleukin-6, interleukin-10, tumor necrosis factor alpha, much higher compared to those in younger people. And this has also been linked to gut dysbiosis. So there's so much that has to do with lifestyle. And I think this is what Professor Bakwen was trying to say, that we don't start from the age of 40 or 30 and start saying do exercise, eat right. It has to be a life course approach. I guess a picture here tells us that with aging, there's reduced muscle mass, so reduced blood oxygen extraction. There's increased collagen deposition, in the smooth muscles, and you have, with obesity, increasing risk of obesity. Also with aging, that increases risk for hypertension. Diabetes also increasing risk for hypertension, and all of those with smoking and dyslipidemia, increasing the risk for atherosclerosis. The atherosclerosis has also been linked to pro-inflammatory state with the endothelial dysfunction and the risk of plaque rupture. And all this increasing risk for angina, and that can lead to disability. We already have in our older, especially the frail older people, who already have issues with walking from degenerative joint disease, or those who might have sensory impairment that also affects ambulation. So if you already have an older adult with this existing conditions, with sarcopenia that also reduces ambulatory capacity, and on top of that they have existing hypertension, diabetes, it really makes them a lot more vulnerable for poorer outcomes. So I think I sort of explained all this. So key concepts with aging. We describe homeostenosis, which is the progressive dwindling, which we find of our physiological reserve. I already talked about inflammation, which increases risk for CAD, MI, and stroke. We also have immunosenescence, where older people are not able to mount an adequate response to infections. So they tend to have more severe forms of infections, like pneumonia. When you get sepsis in an older person, it tends to be a lot more severe, and they also have the risk for poorer outcomes. In the geriatric age, we're very concerned about functional capacity, which is, be it physical, the capacity to move, the capacity to see, hear, and all of that, which we all come under what we describe as healthy aging. And the WHO has actually given us a compass, for member states to look at, ensuring, things that must ensure that as their older persons or as their citizens are aging, they actually remain healthy. They have capacity to do what they desire to do. And that capacity can only come from people remaining as healthy as possible. That functional capacity would also include cognitive function. So where we're looking at depression, we're looking at also psychological issues like anxiety, which we also find very commonly in the increased, older adult population. Somebody retires, they have a lot of anxiety about how life is going to be subsequently. Do I have enough funds? If you find a 65-year-old who still has children in the secondary school, they have a lot of anxiety around things like that. So we also look at quality of life. So these are two major things that we focus on. Functional capacity, how do we preserve functional capacity to ensure that quality of life is as optimal as possible? And so being able to provide aids that would actually help with function, it's very important as we manage our older adult patients. The other major, syndrome is also frailty, and this is something that, as we are managing our older adult patients, that will pay attention to that. So we've heard about hypertension already from Professor Mbakwe. Just to say that in our older adult population, isolated systolic hypertension is dominant, and it's actually been found to be a strong risk factor for incident cardiovascular disease in older adults, even in those who are 80 and above. Let me say that sometimes, and we're all guilty of it, even as healthcare workers, where we practice what we describe as ageism. So an older adult who is 80, you think, oh, well, this person's already 80. We don't need to bother about doing a lot of things for them. As long as the individual has the desire and they have the support of family members, we should definitely do all that we can to add life to their years and not discriminate against anyone on the basis of age. So if in an 80-year-old, increased systolic blood pressure remains a strong factor for incident cardiovascular disease, we definitely also want to give that 80-year-old access to good quality healthcare. We know that there were recommendations, in the old, where we felt, oh, if you're 60 and above, we don't need to bring your systolic blood pressure below 150. But we know that recommendation is obsolete, and the lower the better. The only caveat for us in geriatrics is when you have a frail older adult who is at risk of orthostatic hypotension, we must have a balance. So you're looking holistically at the individual and not just that blood pressure reading. Diabetes also confers increased risk of cardiovascular disease. So I had mentioned to you earlier, these are really the top two chronic medical conditions that we found in our older people. This is also just to say that for lipids, we still have to pay attention to lipid control, and they are of benefit, especially up to the age of 80. We all know about that, the 4 tables that tells us about lipid benefit groups. But beyond the age of 80, we're really not sure what the benefit is for this older adult. So it's quite uncertain. Smoking is also a major cardiovascular risk factor. We tend not to find a lot of our older adults smoking cigarettes, but in the rural areas where we find more than 70% of our older adult population in Nigeria, they indulge in tobacco use in the form of the snuff and the chewed tobacco. And when we take history regarding tobacco use, we must really remember that. I think it's really just talking about the fact that with increasing age, we're definitely getting an increasing number of prevalence of cardiovascular disease. This, I just wanted to use this to show that there are actually cases of non or subclinical cardiovascular disease where it's only during postmortems that you're actually finding people who have significant coronary artery disease that might have died, from maybe a silent MI. But again, there's an increasing risk of all of these endpoints of cardiovascular disease with increasing age. Now, it's said that after the age of 85, there is a reverse. So up until the age of 80, 85, you have a higher prevalence in men. We have a concept that we describe as feminization of aging, and you wonder if that is what actually explains that switch that we find after the age of 85, meaning many of the men had actually passed before that age. And so when you do a comparison, because you have many more women, it might look like you have more women there. Okay, so while we look at cardiovascular health, we also want to remember that these are a cohort of patients who have other things existing or who might have other things coexisting. So cognitive impairment, dementia, we see higher prevalence with increasing age, falls and mobility issues because of the degenerative joint diseases combined with issues of sensory impairment. So they have visual loss, hearing loss, all that also increase their risk for falls. The risk of polypharmacy, because with the multimorbidity, it means you might, sometimes one patient is on 7, 8 medications, 3 for blood pressure, 2 for diabetes, maybe cholesterol lowering, maybe an antiplatelet. So, and also maybe analgesic. So that risk for polypharmacy and adverse drug effects is really high in this population group, and we have to ensure that we pay attention to that. We describe polypharmacy as the presence of 5 or more medications in any one patient, and the prevalence of polypharmacy in a patient population is as high as 70%. So we really something that we need to pay attention to. Anxiety and risk of depression also we see very high, 2 common psychological issues that we find in our older people. And we again have tools to assess for this, which we would encourage that we all use, especially in geriatric cardiology. And I think I'm going to talk a little bit about that. I would like us all to pay attention to the 5 M's of geriatrics. Again, just helping us to bring to fore this geriatric syndrome. So mind issues, mobility issues, medication issues, and the multi-complex issues that we find with aging. So because of multimorbidity, the effect of aging, there are changes in the way older people present for disease conditions, and not just for heart conditions. You find an older person who has sepsis who's only just presented with a loss of appetite, just a loss of interest in the activities they would typically participate in. So presentation is atypical, so we must have a high sense of suspicion for say coronary artery disease or an acute MI. Presentations also can be very non-specific, restlessness, confusion. So whenever we see this change, so with aging, especially with the frail older ones, you tend to see just a change in their more like a psychological change. Somebody who will now be sleeping excessively, wouldn't wake up to eat their meals, or have some disorientation. They lose interest. Or mommy that would often go to church every morning suddenly doesn't wake up. So we must always think, what could be amiss in such an older adult? And occasionally you'll find specific symptoms like syncope, shortness of breath, and all of that. But more commonly, their presentation is quite atypical. So proportion of patients with acute coronary syndrome who present with chest pain, much lower in the older adult population compared to the younger ones. And they are also, because the symptoms are so atypical, it means that there often tends to be a delay even in presentation, a delay even in diagnosis if the healthcare worker is undiscerning. And that means poorer outcomes, which would then explain also why mortality for older adult patients with ACS will be higher than younger ones. We talked about this. Also, when we do stress testing, because of the underlying aging changes and the multimorbidity, you might not find your typical signs, and you might also find you're more likely to get false negative signs because of all that all the underlying multimorbidity that they have. So we also find valvular issues with aging. The very common one we tend to see is, increased calcification around the aortic valve, and it can actually give them an aortic sclerosis. And so when we listen to the chest of our patients, you might actually find murmurs from aortic sclerosis, and an echo would help in identifying that. One other common thing that older adult population would tend to have is cardiac arrhythmias. Atrial fibrillation we find commonly, be it paroxysmal or persistent, and again, presentation is very atypical, and the degenerative changes around the sinoatrial and atrioventricular nodes also affect the arrhythmias that we find in this older adult population. We might, however, find some, very occasional supraventricular ectopy, short runs of SVT, and very commonly premature ventricular beats in this older adult population that do not necessarily mean that they have pathologies. Peripheral arterial disease is another cardiovascular issue. I just brought this out here to, draw our attention to abdominal aortic aneurysms, which are often asymptomatic, and there are those who are at risk that we really must assess for this. Men over the age of 70, especially if they have smoked, and history of hypertension, to really be able to examine when we do our abdominal exam, looking for the expansile pulsation, and you can go on to do an ultrasound scan that will help us with that. Yes, actually, yeah, running up. So in treating CVD in older persons, we have to adopt a holistic approach. Pay attention to the multimorbidity, the risk of polypharmacy and adverse drug effects. Involve patients and family in care planning. Avoid intense control of hypertension and DM in our frail older persons. So we don't want to increase, give them poorer outcomes because of our intense control. Especially for those who have frailty and those who have dementia. Avoid ageism, meaning discriminating on the basis of age. Ensure that, routine medication review is done. And this is something we do at every clinic. We ask our patients to bring their medications so that we can deprescribe what is not necessary to be able to reduce polypharmacy and adverse drug effect. For the care of older persons, we recommend a multidisciplinary approach, and we recommend that a comprehensive geriatric assessment is actually deployed, and this is where the geriatric cardiology comes into play. If we're having many more older people in the world, we definitely need cardiologists who have expertise in this, and the plan is that we strive to add life to their years and not just prolong life with disability. This is just the domains that the CGA should focus on: mental health, physical health, socioeconomic. Professor Mbakwe mentioned those wider determinants of health, and they fall under that. Capacity and advanced directives, very important with our older adult population who might have terminal stage heart disease or heart, and you need to know what their preferences would be if anything was to happen to them in the event that something happened to them. We've already heard about this, but again, to mention that stress management is key across the life course, because excessive or undue stress has been shown to be pro-inflammatory. The surge in the catecholamines not helping blood pressure control, and the risk to the endothelium and that risk of plaque rupture. Sleep has also been associated with poor health. We almost ensure 7 to 8 hours of sleep. Social isolation has also been associated with poor health reduced lifespan. So, life course approach, imbibe the 6 pillars of healthy living, annual health checks for early detection, immunization for vaccine preventable diseases. We know that in our older people, an episode of pneumonia could be a risk factor for them getting an acute heart failure event. So ensuring that those who need the pneumonia vaccine get it, that would actually help with that. Managing emerging age-related diseases promptly, avoiding undue stress, appropriate diet that's low in salt and high in plant-based, like the people of the blue zones who tend to live beyond 100, and then optimizing BMI. It's important that there's shared decision making in managing older people for whatever condition, but particularly so because we're talking about cardiovascular health. Thank you very much, and I will stop there.
Thank you. Thank you, Dr. Silgu, for your elaborate and well-structured presentation. Thank you so much. I think I'll call on the Omron group to quickly, the New Health Farmer, to quickly bring in their presentation so that we move to the last presenter. Tayo.
All right. Thank you very much, sir. Good evening once again, everyone. All right. Please confirm that you can all see my slide.
Yes, we can.
Okay. Yeah. Thank you. Yeah. So, happy World Heart Day once again. I said earlier, my name is Taiwo Ladito. I am the product manager for the Omron category with New Heights Pharmaceuticals. And today, like our professors have been speaking about the healthy heart across all ages. And here today, we're partnering with the Nigerian Hypertension Society to ensure that we express this to everyone, we understand what it means, and that we are better equipped to manage our heart across all health. Most importantly, is that we don't miss a beat. All right, New Heights Pharmaceuticals is the official business partner for Omron in Nigeria. So when you talk about the Omron blood pressure monitors and all the ranges, including nebulizers and scales, all right, we talk about the product being distributed in Nigeria by the New Heights Pharmaceuticals, all right? So the question we are going to push to us is why the Omron blood pressure monitors? A lot of people say my doctor recommend the blood pressure monitor, but it indicates that I get an Omron blood pressure monitor. So the question we are asking is why do your doctors recommend Omron blood pressure monitor to you, or why should you as a doctor recommend an Omron blood pressure monitor? There's some points to note when we're talking about Omron blood pressure monitors, and we know that at Omron the intention is that we offer an entire line of devices that are comfortable to use at home and provide quality and accurate, reliable result every time and everywhere. Our ranges of blood pressure monitors are clinically validated devices, which guarantees accuracy every time you pick a device to check your blood pressure. We also say that our devices have a 5-year warranty. Okay, you are guaranteed for the next 5 years on your device, and we are #1 global brand recommended by cardiologists across the world. So we go further to explain why the Omron blood pressure monitor. We say that because it helps to diagnose and monitor hypertension with accurate results as in your doctor's office. So when you use the Omron blood pressure monitor in the comfort of your home, you are sure to get accurate blood pressure readings as in your doctor's office. So doctors should also remember that when they are recommending a blood pressure monitor, the name to give is the Omron blood pressure monitors. Results are accurate. They are easy to use at home, at the convenience of your home, easy to use, easy to take your readings, convenient reading and reliable results. Our range of blood pressure monitors can detect irregular heartbeats and also atrial fibrillation. So doctors, you should know that your devices, okay, can help your patient screen for that. So we've gone beyond just a blood pressure check. We are now going for that to say we are trying to prevent stroke. And how do we do that? Our devices are able to detect regular heartbeats and atrial fibrillation. We also have a other range of features that make our devices unique and exceptional, and they include IntelliWrap Curve, which gives you accurate reading at any part of your arm when you're taking a blood pressure reading. The Omron app is also available to share your results with your doctors, okay? If you have a device or your family member, or you have an elderly one in the home that you want to check that result all the time. So you have the app that is easy to connect by Bluetooth to your phone, and then they share with their healthcare professional or family members. All Omron blood pressure monitor in Nigeria with the hologram seal are NAFDAC registered, and we have the after sale support for your devices for the next 5 years. So you have warranty assured on your devices. So who can benefit from choosing an Omron blood pressure monitor? We have anyone that is regularly, okay, wants to monitor their blood pressure results occasionally or regularly. They need an Omron blood pressure monitor. If you're pregnant, it's important that you also benefit from using an Omron blood pressure monitor. A diabetic individual, okay, anyone living with diabetes, it's also important that they check their blood pressure regularly. Or if you have high reading in your doctor's office, okay, this can be a sign for white coat hypertension. So it's important that you also check at home to help you inform your doctors appropriately or your healthcare professional appropriately on your blood pressure reading. If you have been started on blood pressure medication, okay, it's also important that you get an Omron blood pressure monitor for home use. Or if you have normal blood pressure and you just want to keep your eye on your blood pressure readings, then you should go for an Omron blood pressure monitor that gives you accurate results every time you use it. So I'd like to share this video briefly. Okay, I hope you can hear my, you can hear my video. This video is explaining the features on our devices and how efficient the improved features are. Yeah. Our technology provides accurate readings every time. Exactly. Every time you pick a normal blood pressure monitor, accuracy is assured. Our devices also help to detect atrial fibrillation. All right, so welcome back from the video. I'm sure everybody saw the video and is giving us assurance on all our Omron range of blood pressure monitors. We say that if you walk into the pharmacy, you want to pick an Omron device, pick the one with the hologram seal, which you see the NHP hologram seal on the device, and then you are assured of the authenticity of your device from any reputable pharmacies or online on www.healthace.ng. It's important to also say that there is a promo code going on, okay? The flyer will come on board shortly. And if you want to pick a device within the next 24 hours, please visit our e-commerce store, which is www.healthace.ng, and stand the chance to have discount on your purchase. Just use the promo code and then the discount will be offered. This offer lasts for the next 24 hours. Thank you very much for your time. Thank you, everyone. So I hand over to you, Dr. Fasto.
Thank you, Taiwo. Time is fast spent, so at this point we will just invite Professor Nalo. So I apologize. I initially introduced him as an associate professor, but I later found out that he's a full professor of pediatrics at the University of Abuja Teaching Hospital. Professor Nalo.
Okay, thank you so much for the opportunity to come on board Again, sorry for the, the slide problem that I had earlier. So I thank you for.
So can you see my slide?
Yes, I'm seeing your slide now.
Okay, great.
Yes.
So I'll
So
just speed up
yes,
to here.
yeah, we've gone through the basic pathophysiology of these heart conditions. So we're talking about the congenital acyanotic heart diseases, looking at the pathophysiology. On this slide, you see we are talking about here the moderate to large VSD. Um, it's associated with a high pulmonary blood flow, and because of that, there's a high blood return to the left atrium, the left ventricle, and commonly they have left atrial enlargement and left ventricular hypertrophy. Because of the increased volume in the left side of the heart, the patient could have left ventricular failure. Next slide, please. Similarly, for those with PDA, they also have increased pulmonary blood flow. You can see in the picture there, there's increased shunting from the descending aorta to the pulmonary artery, and that will increase return to the left atrium and left ventricle, and they may present with left ventricular failure, as we saw in the case of US. Next slide. The ASD is slightly different. In the ASD, the volume overload is on the right side, and therefore they may have a right atrial hypertrophy and right ventricular hypertrophy. Next slide. So in terms of the manifestation, for those that have small shunt, they may not have any clinical manifestation. Or you may see an asymptomatic patient with incidental finding of a murmur. But for those with moderate to large shunt, the increased pulmonary blood flow is associated with pulmonary congestion and pulmonary edema. And this will present clinically as recurrent cough, recurrent chest infection, breathlessness. This will impede on the feeling of the patient and will present as failure to thrive. The shunt also may result in a systemic starvation because of the still phenomenon, and this will also give rise to failure to thrive. Next slide. When you examine this patient, they are generally small for age, they are dyspneic, they have precordial bulge, hyperactive precordium. The pulses may be bounding in the case of PDA, and they may have a displaced apex, especially when there's left ventricular hypertrophy and when they are also in cardiac failure. There may be right ventricular heave, and a systolic tree may be palpable depending on the type of heart diseases. For PDA, you may palpate a systolic tree in the left upper spinal border or at the left lower spinal border in the case of a VSD. Next slide. The blood pressure are generally normal in most of them, except for PDA, where there may be a wide pulse pressure. The heart sound, first and second heart sound are normal, but in the case of atrial septal defect, the splitting may be fixed, whereas while the second heart sound, which is the P2, may be loud, indicating a pulmonary hypertension. Murmur heart is determined by the type of heart disease you are dealing with. For atrial septal defect, you may hear injection systolic murmur, while in the case of PDA, there may be a continuous murmur at the left upper spinal border. Systolic murmur is often heard in those that have BSD. Next slide. When we investigate this patient, the chest X-ray will be normal for those with small shunt, and you may see evidence of cardiomegaly in the case of those with light to moderate shunts. The ECG also will demonstrate a left atrial enlargement, left ventricular hypertrophy, and left atrial fibrillation in patients with BSD and PDA, while the ASD group may show right atrial enlargement and right ventricular hypertrophy. Echocardiography will show the size and the site of your defect, while cardiac catheterization will help you to further confirm what you are seeing in the echo. Next slide. Complications that are often found in left to right shunt include recurrent chest infection, heart failure, failure to thrive, infective endocarditis. And of course, the infective endocarditis is common except for those that, except for ASD, in which case it is very rare in ASD. Otherwise, VSD, PTA, they may have infective endocarditis. It is nice, it is important to mention here that most VSD, most ASD close spontaneously. Next slide. Treatment-wise, we have two categories, medical and surgical. The medical is directed at the control of cardiac failure and also nutritional support and treatment of endocarditis. Surgical treatment is in terms of pulmonary artery banding and definitive repair of the defect. Next slide. The timing of the defect, or the intervention of the defect, for a atrial septal defect, the indication is only when there is right ventricular volume overload. Otherwise, you just watch. Because most of them close continuously, except for those who are more than 8 millimeters that are unlikely to close. For patients with irreversible pulmonary vascular disease, closure is contraindicated. The ideal age in those that have RV overload that are asymptomatic is between the age of 2 to 4 years. And the closure method, either a device closure or by surgery. Next slide. The VSD, for those that have VSD with small defect, you don't do it, you just follow them up. You only close if they develop infective endocarditis, aortic valve, prolapse, or right ventricular obstruction. That's the only time you need to close a small VSD. For moderate VSD that are symptomatic, you may give up to 2 to 5 years before you close them. The symptomatic type depends on whether the heart failure is controlled or not. Those that have uncontrolled heart failure can close them as early as 6 months, while those with controlled heart failure, you may want to wait for 1 to 2 years before closure. And the method of closure here, both either a device closure or a surgical closure. For those that would benefit from device, it's important to know that not all patients that are deviceable. They should have a weight of at least 8 kilograms, simple type of VSD like a muscular VSD, a perimembranous VSD that is at least 4 millimeters away from the aortic valve. Those with bundle branch, conduction abnormalities, aortic regurgitation, inlet or outlet VSD, and presence of other lesions are not candidate for device closure. This one should be closed by surgical means. Next slide. For the ductus arteriosus with a left ventricular volume overload, you have to do something about them, provided you don't have pulmonary vascular disease. For those without pulmonary vascular disease, you may decide to close them depending on how the patient presents. Those with congestive cardiac failure and hyperkinetic pulmonary hypertension, you may want to close as early as 3 months. While those that have moderate PTA and without congestive cardiac failure, you may decide to choose between 6 to 12 months to close. Small PTA may wait for as long as 18 months, while silent PTA will not need any intervention. I need to mention here that PTA in preterm babies respond to drugs such as indomethacin, ibuprofen, and currently they are talking about use of acetaminophen, which is a paracetamol. In the next slide. The atrioventricular septal defect, in this group of patients, surgery is the only method of closure. And those that present with complete ABSD and uncontrolled heart failure, you have to operate immediately. While those with controlled heart failure, the repair can be done by the age of 3 months. Those with partial ABSD and intermediate ABSD can wait for as long as 2 to 3 months. Next slide. For the obstructive lesions, pulmonary stenosis, we know that they have 3 types: the valvular, subvalvular, and the supravalvular. The main problem here is obstruction to the right ventricular outflow, which will give rise to increase in right ventricular pressure and lead to right ventricular hypertrophy. In severe cases, they may come down with right ventricular failure. Fortunately, this is not common. Next slide. The finding in them is dependent on the type of the severity of the obstruction, and the site. The patient may be asymptomatic. Some may come with easy fatigability, chest pain, and in those with critical pulmonary stenosis, you may find cyanosis. This is very, very rare. Next slide. You may find that the patient has the right ventricular heave, asystolic tree in the pulmonary area, ejection click, and a single soft second heart sound may be picked. Patient, you may find ejection systolic murmur at the left upper spinal border. Heart failure is very, very uncommon in patient with pulmonary stenosis. Next slide. So when you investigate them, the chest rate may be normal. They may have a post-natal dilatation of the pulmonary artery, and there may be a decreased pulmonary vascular markings. Often they are normal, but they may have that. ECG will reveal right ventricular hypertrophy with axis deviation. Echo will show you the site and the severity of abnormality, which will be confirmed with cardiac catheterization. Treatment, for those that have mild pulmonary stenosis, there's no treatment. For those with severe stenosis, either you opt for balloon valvuloplasty or surgical relief. Next slide. Aortic stenosis is the next common obstructive lesion. Luckily, it is less common compared to pulmonary stenosis. 3 types also that have been found: valvular, subvalvular, and supravalvular stenosis. The supravalvular stenosis is the one I shared with neonatal hypercalcemia. The hemodynamics in this situation is that of obstruction to left ventricular outflow tract, which will give rise to increase in left ventricular pressure and will lead to left ventricular hypertrophy. The obstruction may lead to decreased aortic pressure with decreased volume. Sometimes they may have decreased coronary blood flow, which may appear as myocardial ischemia. When you examine this patient, next slide. When you examine this patient, they may be asymptomatic, and those that are severe, they may have chest pain, exercise intolerance, and they may have small pulse volume, narrow pulse pressure, increased left ventricular impulse, and a trill in the aortic area. The second heart sound may be single. Investigation findings: the chest X-ray may be normal. Next slide, please. Chest X-ray may be normal. Next slide. Next slide. Next slide. Chest X-ray may be normal, or you find it. So when in terms of intervention, aortic stenosis in newborn would have a severe aortic stenosis and duct dependency, and as well as those infants that have left ventricular failure, operation should be done immediately. But for the asymptomatic type, you may need to wait until maybe the gradient across the obstruction is more than 64 millimeter mercury by echo. Those that are symptomatic, have angina, they have easy fatigability or ST changes, they are candidate for intervention. And the ideal age, if they are not symptomatic, is between 2 to 4 years. The method of closure will have 2 options, either a device closure or surgery. Next slide. Coarctation of the aorta also is another form of obstructive lesion that we commonly see here, and this presents as obstruction to the left ventricular outflow tract, and will give rise to high left ventricular pressure, and they may have hypertension. Next slide. They have hypertension, commonly present with hypertension, upper limb hypertension, and they reduce volume in the lower limb. Next slide. So again, when you investigate them, unlike the adult that you find rib notching, in children, the rib notching doesn't commonly occur. Maybe you find that in the older age group around those who are around the adolescent time. When you do ECG, ECG will show left ventricular hypertrophy with or without T-wave changes, echo and cardiac catheterization will confirm the diagnosis. Treatment, if you present with failure, especially in infancy, you have to treat medically, otherwise, okay. The timing of, okay, next slide, please, next slide. Next slide. Next slide.
Hold on.
Okay. Okay, sorry.
You have 3 minutes, sir.
I'm almost done. I'm almost done. Those that have coarctation of the aorta, that have pressure more than 20 millimeter mercury, or those that have upper limb hypertension, LVH, they are the candidate for intervention. And intervention, whether with balloon, valvuloplasty, or by surgery. Next slide. Next slide. The cyanotic group, next slide. The cyanotic group, the major problem here is that they have cyanosis. Next slide. And there are three groups. Those that have decreased pulmonary blood flow, like pathology of Fallot. And next slide. It's shown there. That is the example of pathology of Fallot. Next slide. Yeah, the TGA streaming, of course, TGA is not compatible with life. For them to survive, they have to be a shunt, either at the arterial level, ventricular level, or the atrial level. Next slide. The common missing condition, commonly here we see patient with common atrium, truncus arteriosus, double outlet left ventricle. Next slide. Next slide. So in terms of the clinical findings, cyanosis is universal in them, and the cyanosis depend on how severe the obstruction is. Those with increased pulmonary blood flow may present with cardiac failure. Next slide. Next slide. Next slide. Next slide. Next slide. Okay, in terms of investigation, it's very important to mention here that as simple as bedside pulse oximetry will help us to differentiate between cyanosis of respiratory origin from cyanosis of cardiovascular origin. Besides the pulse oximeter, arterial blood gases also will help to also evaluate in this patient. The arterial blood gases will both differentiate respiratory from cardiovascular and also differentiate the cardiovascular that are associated with high pulmonary blood flow from those with low pulmonary blood flow. Next slide. So when you take the blood, generally some of them they may have polycythemia because of the chronic hypoxia, and because of the high erythropoiesis that they have, they tend to have iron deficiency. Even though they are polycythemic, they have iron deficiency. The platelet will reduce, and some of them may have high white blood cells, especially when they have infection. The cerebral biochemistry mainly refers to metabolic acidosis. Next slide. X-ray findings is important because from the cardiac seal heart, you will be able to determine, guess the type of heart disease the patient may have. For example, you may see the bush-shaped heart in the case of tetralogy, or the egg on site in the case of TGA. Next slide. Next slide. Next slide. That's also showing the cardiac seal heart. Now that is the bush-shaped heart and the egg on site demonstrated here. Next slide. Now this is showing the figure of A, the snowman sign, and then the bus-like heart that you find in Epstein anomaly. Next slide. Next slide. ECG, depending on the type of heart disease you are doing, ECG will show right ventricular hypertrophy with right axis deviation, especially in tetralogy of Fowler or pulmonary atresia. While those that have tricuspid atresia will show right atrial hypertrophy with superior axis. Next slide. And 2D echo and cardiac catheterization will help to diagnose. Next slide. So the treatment is very important, and especially some of those that have present with high blood flow, they may require early treatment. While those that have decreased blood flow, in that case, you may have time to evaluate your patient and then treat later. It's important to mention that Raskin balloon septostomy is life-saving in patients that have TGA. Luckily, it's a very simple procedure that can easily be done if the facility is available. Next slide. So the treatment could be medical or surgical. The medical treatment is focused on the control of heart failure, preservation of ductus arteriosus in patients that have PDA-dependent lesion, and the treatment of the hematological complication associated with it's important to mention that we need to know how to identify hypertonic spell and to treat them because it is very, very lethal. If you don't identify it, the patient could easily die from it. And the main goal of treatment is to break the spell that is causing the spell by increasing the pulmonary blood flow. And by bedside, it can calm the patient down initially, ensure that the patient is kept in knee-chest position, administer supplemental oxygen. Next slide. If no response, you can give bolus IV fluid or subcutaneous or intramuscular morphine. Beta blockers are very, very helpful to reverse the spasm. And those that are not responding, IV sodium bicarbonate may help to improve the acidosis. When if patient refuses to respond, then other modalities will include the use of ketamine.
You have a minute. You have a minute, sir.
Okay, next slide.
Are you there? Are you muted? Hello, sir. Okay. I think he's off now. Okay. The slides are almost done.
Yeah, if you're unable to hear him again.
Yes. Okay. So thank you so much, Professor Onalu. That was a very exhaustive presentation, and we appreciate your presentation. At this point, can we just take a few questions if there are any?
Okay, good evening.
Yeah, good evening.
We handling the question and answer session. We're going to be very brief because questions are few. Indeed, some of them have been answered already, but just for the benefit of the rest of the audience, we may just want to ask them. There are two questions here for Professor Mbakwe. One of them says that I've been having intermittent palpitations, visited cardiologist, and shows normal readings in chest done, but the symptoms still persist. and she wants the input of the cardiologist. Again, we have another question that says, which position is the best position to lie down on bed, to the right or to the left? Professor Mbakwe, please.
Okay, so thank you for the question. I actually had responded to the one about the palpitations. So what our advice is for whoever is involved to get a Holter monitoring done, because if you're having arrhythmias and it's not happening at the time the rest ECG is being done, we may not pick up anything. But if you do a 24-hour Holter monitoring, then they're more likely to pick up the arrhythmia. But then the person asking the question says that the palpitations occurs when at rest and in a quiet room. So we also know that slim people, especially when they lie down on their left side, can actually hear their heartbeats, okay, which is normal in a quiet environment. So once that rate is normal and the beat is regular, we don't really bother about it. So we are more worried if it's fast, if it's irregular, but you need to get a Holter monitoring done, so we are sure that nothing is really, nothing sinister is going on. And for the position to lie down, please, whatever position you find comfortable. Most people don't even sleep in one position. Maybe you go to bed on your right, you wake up on the left, or you're on your back when you wake up. Please, whatever position you find comfortable. Thank you.
Thank you very much, Prof. The other set of questions will go to Taiwo from New Heights Pharma. She's answered some already, but again, for the benefit of the general audience. First question, among the Omron monitors, which monitors detect atrial fibrillation? Again, how do the monitors detect atrial fibrillations? How do you go about using to detect atrial fibrillations? And finally, which brand of batteries do you recommend for Omron blood pressure monitors when the follow-come batteries have been spent?
All right, thank you very much for that question. Okay, the Omron ranges, okay, are available in pharmacies, in reputable pharmacies close to you, and all Omron blood pressure monitors, okay, the authentic one, like I said earlier, comes with the hologram seal of the New Heights Pharmaceuticals, that's the NHP hologram seal. So when you're picking an Omron blood pressure monitor from a pharmacy, ensure that the one you're picking comes with the hologram seal, because that's what gives you your 5-year warranty. Now, when you're also choosing an Omron blood pressure monitor, okay, all our ranges can detect irregular heartbeats, but we have some selected range among all our clinically validated devices that are able to detect atrial fibrillation, and that is the Omron M6 Complete and the Omron M7 IntelliIT. So these devices have been built in such a way that they are able to detect atrial fibrillation when taking a blood pressure reading. However, you need to kickstart or activate the atrial fibrillation mode on your device. So how you do this is to press your start button for longer, okay, for 2-3 seconds longer, and then it takes you to the AF mode. AF mode means atrial fibrillation mode. At this point, it takes your reading 3 times at the 30 seconds interval of rest, and then comes up with an average result. If atrial fibrillation is indicated in that reading, during the 3 readings, in any of them, it comes with the atrial fibrillation icon on your screen. So you see the atrial fibrillation icon on your screen, and these are indicated at the back of your box when you purchase one. It's going to be a video that will come up at the end of this presentation. Just stay tuned and then check out the video, and then you see some of this. And if you need to get back to us or you have further questions, you can visit us on our website or on our social media platform, like our pages, ask questions. We'll be there to answer your call our hotline, and we are here to give you the support to your device. Lastly, for batteries, check up any good battery in the pharmacies or on supermarkets. Sometimes I recommend Energizer batteries, but the best ones are the ones that come with our devices. Thank you.
Okay, So thank you to our panelists for your insightful, valuable answers, and to the audience for their thoughtful questions. This brings us to the end of our Q&A session. Dr. Fassan, over to you. Thank you.
Okay, thank you so much. I want to sincerely appreciate all those that have stayed glued to their seats in the past 2 hours that we've been on this program. It shows evidently that it's an interesting one, and I'm sure they must have learned a lot. Everybody has learned a lot in this presentation. Just to say briefly that at the Nigerian Hypertension Society, we welcome new members, and of course, hypertension is everybody's business. So we welcome everybody who is interested and wants to be part of us. We have a website. It's called the tnhs.gov.ng. tnhs.gov.ng. You can go there and you can follow through to membership. There's certain forms to fill out, and then after that you can make your payment. And once you do that, we have your name and your identification. And at the next NHS conference, which is coming up next year in Port Harcourt, if you come over, we will then swear you in as a new member of the society. So we appreciate everybody. And I would love to call on Professor Simeon Isezo to give the final remarks.
Thank you. Thank you very much, Dr. Faso. I want to thank all the participants, particularly our very erudite resource persons, Professor Ama Mbakwem, Dr. Oshogu, and Professor Onoja, for all your very erudite presentations. I'm particularly happy about the questions. It means that the people that the program is actually meant for, who specifically the lay people, talking about heady hearts, were listening, and most of the questions came from them. On the issue, let's emphasize that, Dry said, there's this common, the cheap battery, that when you live in the Omron on any of those equipment for a long time, they get rusted. I hope Taiwo, you are listening, and that may spoil the machine. So that should be category of, because some people may forget the battery in the Omron equipment for months. So I think we have had a very useful time. A lot of new information has been disseminated to us. So once again, I want to thank Omron, our very able partner. We thank Dr. the faculty there at JP handling the secretariat. Thank you very much. As we usually see, every effort we put in is reducing somebody's blood pressure somewhere. Thank you very much.
Thank you so much, sir. So I believe at this point, we've given it a long shot, and it's a fantastic presentation. Once again, thank you to everybody, and congratulations on a lovely webinar and a fantastic World Heart Day commemoration. So thank you, Omron. Thank you, New Heights Pharma, and New Heights Pharma. Good. I think at this point we should call it a day and say, have a lovely evening, everybody.
Thank you so much.
Thank you. Thank you very much.
Thank you. Thank you.
This is an easy way to help
Thank
keep
you,
track
bro.
of your health.
Thank you.
Which is
Thank
why
you,
we
Taiwo.
developed
Bye-bye.
the new Omron M7 IT blood pressure monitor with improved features
Thank you, bro.
and
Yeah,
a more
yeah, I
intuitive
can
design.
see what you're
And because
doing.
our unique IntelliWrap technology makes it easy to get an accurate reading from any position around your upper arm, you have one less thing to worry about. Our built-in AFib indicator function allows home monitoring of atrial fibrillation, an often undetected heart condition, which can lead to stroke. And with Omron Connect, your blood pressure data is at your fingertips, so you can easily track your results and share them with your doctor. Omron, the easy way to get accurate results, so you can get on with the things you love to do. Dedicating just a couple of minutes a day to monitor your blood pressure is an easy way to help keep track of your health. Which is why we developed the new Omron M7 Intelli IT blood pressure monitor with improved features and a more intuitive design. And because our unique IntelliWrap cuff technology makes it easy to get an accurate reading from any position around your upper arm, you have one less thing to worry about. Our built-in AFib indicator function allows home monitoring of atrial fibrillation, an often undetected heart condition, which can lead to stroke. And with Omron Connect, your blood pressure data is at your fingertips, so you can easily track your results and share them with your doctor. Omron, the easy way to get accurate results, so you can get on with the things you love to do. Dedicating just a couple of minutes a day to monitor your blood pressure is an easy way to help keep track of your health. Which is why we developed the new Omron M7 Intelli IT blood pressure monitor with improved features and a more intuitive design. And because our unique IntelliWrap cuff technology makes it easy to get an accurate reading from any position around your upper arm, you have one less thing to worry about. Our built-in AFib indicator function allows home monitoring of atrial fibrillation, an often undetected heart condition, which can lead to stroke. And with Omron Connect, your blood pressure data is at your fingertips, so you can easily track your results and share them with your doctor. Omron, the easy way to get accurate results, so you can get on with the things you love to do.